Hi folks, we've got people popping in. Thank you for joining us this afternoon. We will be heading into our session very soon. My name's Gail Easton. I'm the Program Manager for the Community Drug Action Team across New South Wales. We're providing this opportunity for everyone this afternoon to help all of us have a greater understanding of what is evidence-based primary prevention. I'd just like to first start with acknowledging the rich cultural and spiritual connections of the Aboriginal people of the country that I sit in today, which is Wonnarua country, and respectfully remember the footsteps of our ancestors who walked this land before you and I, and for all of those who will follow. Again, thank you for joining us this afternoon. I'm now going to hand over to Tara and Emma, who are going to be our facilitators and take us through some learnings of primary prevention. Thanks, Tara. Thanks, Emma.
Thank you, Gail, and we're very grateful to be here today. And the Matilda Centre is really excited to be partnering with Odyssey House and the CDAPs for this 4-part series. I'd also just like to start by beginning our session with an acknowledgement of country. I'd like to acknowledge the traditional owners of Australia, and I recognise their continuing connection to land, water and culture. I'm currently on the land of the Gadigal people of the Eora Nation, and I pay my respects to their elders past and present. And I further acknowledge the traditional owners of the country in which you are on, and I pay my respects to their elders past and present. I'd also like to acknowledge any Aboriginal and Torres Strait Islander people who may be joining us today. So I'll just quickly go through some housekeeping points. So as participants to this webinar, you are currently on listen-only mode, and this means that we're not able to hear or see you. And we're also recording this session and we'll make it available to you along with the slide handouts afterwards. We've also got time for some questions and answers at the end of the session. So please, as the session progresses, feel free to add those. You should be able to see a Q&A box on your screen on Zoom there. So presenting today will be myself and Dr. Emma Devine. I've been working at the Matilda Centre for the past 2 years as a research assistant, and I mainly work across 2 projects. So the first one is Positive Choices, which is an alcohol and other drug prevention website, and Inroads, and that's an early intervention for young people with anxiety and alcohol use concerns. And Emma, I'll let you introduce yourself.
Thanks, Tara. I'm Emma, and I've been working here at the Matilda Centre for about 3 months now, so I'm a little new, but I work with Tara on Positive Choices as well. And also on a FASD initiative, so resources for primary school educators around fetal alcohol spectrum disorder. I also have a couple of different research projects that I'm working on that really centre around prevention, mental health and substance use.
So I thought I'd just quickly start today by giving a brief introduction to who we are at the Matilda Centre and the type of research and work that we do. So here's a photo of some of us back at the start of the year when we all weren't working at home and we could all gather in person. So what is the Matilda Centre? So the Matilda Centre for Research in Mental Health and Substance Use is a multidisciplinary research centre committed to improving the health and wellbeing of people affected by co-occurring substance use and mental disorders. And while we do have a large focus on alcohol and other drugs, we also know that many people who struggle with substance use also have mental health concerns. And that's why a lot of our work does focus around comorbidity of substance use and mental health disorders. And at the centre, we have 5 research streams, which our work falls into. And these are prevention, early intervention and treatment, epidemiology and biostatistics, research development and strategy, and then technology, innovation and translation. But of course, today we're interested in the prevention stream. And then just to complicate things a little bit further, the Matilda Centre is also home to Premise, which is a research centre of excellence. So Premise stands for Prevention and Early Intervention in Mental Illness and Substance Use. So essentially the objective of Premise is to bring together leading prevention and early intervention researchers and translation programs in mental health. And that's across 5 universities here in Australia, and you can see those 5 there. So although the Matilda Centre does have a broad focus, with prevention being one of those things, we also have this research centre where we're really focused on prevention. Now, some information about this webinar series that we're delivering. This series is having 4 sessions, which are going to run each fortnight at this same time over the next 8 weeks. So every Wednesday over the next 8 weeks at 2 p.m, we'll be having these 4 sessions. So today's session is going to be an overview on what primary prevention is and what effective prevention looks like. And then our part 2 is going to be an overview of Positive Choices, which is that drug prevention website that both Emma and I work across. And it's a centralized database for a range of prevention programs and information. And we'll also go into more depth about what it means for a program to be evidence-based. And then in our 3rd and 4th sessions, you'll hear from some other researchers at Matilda Centre who are going to present on specific prevention programs that are available. Part 3 is going to discuss prevention programs which are aimed at a wide audience. And then Part 4 will touch on programs that are specific to different population groups, such as Aboriginal and Torres Strait Islanders. So here's just a bit of a quick outline for today's session. And as I said, we've got time for a Q&A and discussion at the end. So please add any questions or comments as we're going through the session today. So first of all, what is primary prevention? So primary prevention refers to attempts to reduce the likelihood of developing an illness or disorder in the first place and can target whole populations, i.e. universal prevention, or particular groups who are at increased risk of experiencing problems, i.e. selective prevention. So this is sort of the dictionary definition of what primary prevention is. And sometimes it's nice, I think, just to really start with that, to set the scene. Now, today we're obviously going to be talking about primary prevention in the context of alcohol and other drugs. So the aim of primary prevention is to help people avoid the use of alcohol and other drugs, delay or reduce the use of alcohol and other drugs, or avoid the harms associated with alcohol and other drugs. And this is done either through influencing individuals' personal behaviours or changing environmental conditions to help reduce the potential for certain behaviours to develop. So these primary prevention strategies aim to support the safe and healthy development of young people. And we refer to young people because we're talking about prevention. We're typically trying to implement things that are aimed at youth to stop that initiation of alcohol and other drug use. So prevention can definitely go into different populations, not just youth, but a lot of the time prevention can focus on youth. And there are several primary prevention strategies that can be used to reduce harm from alcohol and other drugs among young people. And these typically fall into these 3 categories. So the first one is evidence-based alcohol and other drug education programs. And then you have health promotion and community development initiatives. And then finally, there's reducing the supply of alcohol and other drugs through legislation, regulation, and policy. Now, back in that definition at the start, they used the terms universal prevention. So let's talk about the 3 levels or the 3 types of prevention that we use. So firstly is universal prevention, which is often referred to something that's delivered to an entire population group, regardless of their level of risk. So probably a lot of the work that you do is universal prevention. And next we have selective prevention, and this is targeted to groups that are identified as having an increased risk. And lastly, just at the tip there, you've got the indicated prevention, and this is offered to people experiencing early symptoms of a disorder. Now we can touch on some examples for these different types of prevention. So universal prevention could include something like taxation on alcohol. So back under the Rudd government, there was the Alcopops tax, which was a 70% tax on pre-mixed alcoholic drinks. Or another example of universal prevention would be something such as a drug and alcohol program delivered to all year 8 students. So no matter the type of risk, it's delivered to everyone in a year level. And then when we have selective prevention, this could be a community program for young people who have an increased likelihood of harmful alcohol use behaviours. And this might be young people with a history of violence or family members with alcohol and other drug use. And Emma will talk a bit more about some of those risk factors later on. And we do have a program that targets certain population groups at the Matilda Centre, and that program is called Preventure. And we're going to be talking about that more in the 3rd webinar of this series. And then finally, we've got the indicated prevention. So that's aimed at people with early signs of alcohol use disorder. So that could be an example of a program. And indicated prevention can sometimes also be referred to as early intervention. So you're intervening amongst people who are already showing signs or symptoms of a disorder. So when it comes to primary prevention, there are a number of key stakeholders, and we've listed a number of these in the slide. So these can include people or groups such as the local and national government, health and clinical services, population health professionals, community and local drug action teams, so yourselves, community groups outside of that, so such as sporting clubs. There's also police or community justice department, Then you could have Aboriginal community controlled health services. And then we've got schools, parents, and youth being one of the key stakeholders here because they're often the people that we're trying to target. So what is the role of community in prevention? So evidence continually highlights the effectiveness and importance of community engagement in preventing harms from alcohol and other drugs. So this is especially the case in some higher risk populations, such as young people or Aboriginal and Torres Strait Islander communities, migrant communities, and lower socioeconomic communities. And we know that it's critical that community programs ensure the focus of the program is relevant to the needs of that community. This is where we know that community engagement in program planning, design, and implementation helps to increase the awareness of alcohol and other drug harms. And that's an essential component for ensuring community support and participation. So basically, you really want to get that buy-in from the community to make sure whatever you're delivering is really meeting the needs of the people that you're trying to deliver it to. So we also know that community-led programs strengthen the capacity of the community to identify, prevent, and respond to health issues in a population. Fostering a sense of community ownership is key to engagement and participation in community-led programs. And it also acknowledges that gathering resources and knowledge, as well as coordinating with multiple agencies or sectors, are elements for success. And this collaborative approach is important for long-term effectiveness in programs. And an example of a community-led alcohol and other drug prevention program that is currently being trialled by researchers at Matilda Centre is Strong and Deadly Futures. And this program is a strengths-based Aboriginal and Torres Strait Islander program, and we'll highlight this program more in the fourth webinar of this series. Now let's just touch on supply, demand, and harm reduction. Now, first of all, I just wanted to touch on how primary prevention fits into the National Drug Strategy. So in Australia, the National Drug Strategy is a 10-year plan that aims to reduce and prevent harm caused by drugs. And prior to this one from 2017 to 2026, there was one that was implemented from 2010 to 2015. The national framework is committed to harm minimisation through a balanced adoption of effective demand, supply, and harm reduction strategies. So basically, the National Drug Strategy is what's guiding all the alcohol and other drug-related work that the government is carrying out and funding. So in the National Drug Strategy, harm minimisation includes these three pillars. So the first pillar is demand reduction, and that refers to preventing the uptake and/or delaying the onset of alcohol and other drugs in the community and supporting people to recover from dependence through evidence-informed treatment. And then we have supply reduction. So that's preventing, stopping, disrupting, or otherwise reducing the production and supply of illegal drugs, and controlling, managing, and or regulating the availability of legal drugs. So I will state as well, the drug strategy also covers a lot of the prescribed medications, not just illegal drugs or alcohol. And then harm reduction as well is about reducing the adverse health, social, and economic consequences of the use of drugs for the user, their families, and the wider community. Now, we're just going to run a quick poll here on Zoom to see where people think that primary prevention fits into these three pillars. So I will just launch that one now. You should see it pop up on your screen. So where do you think primary prevention fits into the harm minimisation model? I'll give it a few seconds for people to vote. The responses are sort of split over a few. Give it a few more seconds. Quite interesting actually watching because there is a split across all three at the moment. Just end the poll there. So people should now be able to share the results. So 27% of people said that it fits under demand reduction, 17% under supply reduction, and 57% under harm reduction. So according to the National Drug Strategy, so this is what the government says themselves, they see primary prevention fitting under demand reduction. So primary prevention is harm minimization, and it falls under the category of demand reduction. So it can get a bit confusing where harm minimization is all three pillars, but then within the harm minimization, there's that harm reduction, supply reduction, and demand reduction. So it does actually fit under demand reduction, but we could argue as well that I think we all know primary prevention does fit into a bit of that harm reduction category as well. So typically the prevention is aimed at adolescents and young adults, i.e. before their alcohol and other drug use is initiated. So that's how it kind of fits into demand reduction. So what is the government spending on primary prevention? In general, across Australia and internationally, a much higher proportion of alcohol and other drug services is about funding and activity focused on treating and supporting people to recover from dependence and reintegrate into the community. So this means that there's often less focus on the development and implementation of effective prevention activities aimed at preventing and reducing harm across the whole population. And it's very hard to find sort of exactly how much they're spending on prevention in the alcohol and other drug space, but less than 2% of the national health budget is spent on prevention. So that's across all health issues. Only 2% is being spent on prevention. So we can imagine that when it comes to alcohol and other drugs, that's a very, very small sliver of the pie. And we know that there's often a larger focus on illicit drug use when alcohol and tobacco often have the most harms. So next, let's just touch on some alcohol and other drug use statistics in Australia. So now that we've sort of talked about what primary prevention is and harm minimisation, it's important to touch on how many people are actually using alcohol and other drugs. And when it comes to accurate estimates of youth alcohol and other drug use, there's often two sets of data that we use. So the first is the Australian Secondary School Student Alcohol and Drug Survey. And this surveys young people aged 12 to 17. So before alcohol is technically the age of when you should be using alcohol, and also that illicit drug use. And we can see that for 12 to 17-year-olds, 46% had consumed alcohol in their lifetime, and 5% had engaged in binge drinking. So binge drinking in this case is defined as more than 4+ standard drinks on a single occasion. We can see that 15% have used cannabis, 13% had smoked cigarettes, and 13% have used e-cigarettes at least once. And we know, and we constantly hear from many people, that e-cigarettes are sort of becoming a growing concern. And I think it's sort of hard, what we're seeing in the media, maybe we can't keep up with these stats if they're accurate anymore, but the best estimate we have at the moment is about 13% of people, young people, using e-cigarettes. There are some good news when we're looking at trends over time. So the data on this slide here is from the National Drug Strategy Household Survey. So again, it's related to that drug strategy, and the Household Survey is a large survey that's run every 3 years. So it's across the whole population, not just for youth, but we've pulled the youth numbers here. So the last time the survey was run was in 2019, and 22,000 Australians were surveyed. So when it comes to alcohol, we can see that across the years, more youth are abstaining from using alcohol. Back in 2001, only 32% were abstaining, 2013, 61%, 2016, 73%, and then in 2019, it's sort of stabilizing a bit. We can see that 73% are abstaining from using alcohol. And this is a trend that's sort of happening globally as well, where many youth are actually drinking less than previous years. We can also see that the average age of first drink for 14 to 24-year-olds is sort of getting older. So people are having their first drink later in life, which is good because we're preventing that first drink. So back in 2001, people were having their first drink at about 4.17 years. And then in 2019, 16.2 years. And then when it comes to smoking, there's also some positives. So back in 2001, only 65% of 14 to 17-year-olds had never smoked. But then in 2019, 84% have never smoked. And only one sad thing about the drug strategy survey is they weren't always surveying about e-cigarettes. So back in 2001, they weren't surveying about e-cigarettes. So we don't really have this trend over time, but I anticipate from 2019 when people were last surveyed and when the next survey round comes up, we will get a bit of an idea of how that trend, if there's a trend there with e-cigarettes. So next I will hand over to Emma, who will take it from here.
Brilliant. Thanks so much, Tara. Let me just get the slides up on my end so that I can control my own clicking. That has not worked quite how it did last time, so let me just start that again. So, all right. Thanks so much, Tara. So what I'm going to kick off with and continue on with now is discussing with you the importance of prevention and the age of onset of substance use. So I'm going to start by going through some of the negative outcomes of alcohol and other substance use before moving then into the protective and risk factors associated with substance use onset, which in turn will inform some of the prevention space that I'm going to move into after that. So just to start, it's sort of well established, and I'm sure we're all pretty clear on the negative outcomes that can be associated with substance use. But what's particularly interesting and also relevant in the context of prevention today is that research shows that the earlier a young person starts to use alcohol and other drugs, the more likely they are to experience various negative outcomes. So some of these outcomes include poor school performance and an early dropout. And we know from the research as well that poor school performance and early dropout has a lot of long-term subsequent consequences as well. And these include things like job instability and greater risk of economic instability and difficulty later in life. Young people who start substance use earlier are also at an increased risk of other mental health problems, particularly for depression, anxiety, inattention, and hyperactivity. They're also more likely to become dependent or addicted to substances. So research has shown that for each year we can delay a young person starting to drink or to use other substances, the odds of them developing an alcohol dependence is reduced by 10%. So this is really substantial. And finally, the earlier a young person begins using substances, the greater the risk for juvenile offending, with offences most often including drug-related offences or violent and assault offences. So it's imperative that we prevent or delay the onset of alcohol and other drugs for as long as possible to prevent these negative consequences. It's also important that the prevention efforts, as Tara has mentioned already, are timed prior to the greatest risk of onset. So when young people are most likely to start experimenting with alcohol and other drugs. And doing this will ensure that young people are equipped with the skills and knowledge to make informed decisions and stay safe in situations where they might be involved or exposed to various substances. So in the context of prevention, again, when we look at some of the substance use statistics that Tara showed us about, how many young people are using alcohol and other drugs, how many are abstaining, it's important to consider the different risk and protective factors that may play a role in determining whether a young person is going to be an abstainer or are they going to start using. So protective factors that research has shown include a sense of self-efficacy. So this is a confidence in one's own abilities and in the decisions that an individual might make. The next one then is parental rule setting and monitoring. So it's really important that parents set clear rules and boundaries around not using alcohol and other drugs for their children. It's quite a pervasive belief, or it's often believed by parents, that allowing their teenagers to drink in a controlled setting or providing them with a controlled amount of alcohol is an effective way of monitoring their behavior. But research has shown that this is not the case and that it'll actually increase their overall alcohol use and binge drinking. So just something to bear in mind there as well. Family bonding and communication then. So this would involve things like spending quality time with your children, being engaged and knowing about their friends, and clear, open, honest communication that is free of judgment. School involvement is a really important and powerful protective factor that we've seen. So this might be, the actual schoolwork itself, getting, interested and excited by a subject, as well as extracurriculars and the social side of the school as well. Regarding time spent with peers who do not use drugs or alcohol, and also having positive peer relationships, the research has found that friendships and peers are really influential during adolescence. And that teenagers will in fact adopt their own drinking intake to match that of their friends. So spending time with and being around friends who are not drinking is also a really strong protective factor. for adolescents as well. So research has also identified risk factors which can result in an increased likelihood for early onset of substance use or an increased use. So on this slide, the risk factors have been grouped according to when a young person is most likely to be exposed to or be vulnerable to that particular risk factor. So to begin with the early stage factors, there's been some evidence for an inherited vulnerability to substance use. So in other words, a sort of a genetic predisposition. Maternal smoking and alcohol use is also a risk factor. And there is some kind of recent evidence emerging to suggest that paternal smoking and alcohol use is also a risk factor, but we are waiting for a bit more research to be done in this space. Other early age risk factors include extreme social disadvantage and child abuse and neglect. So moving on then to the school age risk factors, these include early school failure, and this ties into the school involvement that I was speaking about earlier. School failure is then likely to be the poor performance and the increased risk of dropout, which we spoke about as a negative outcome even earlier on as well. The emergence of behavioral disorders like child conduct disorder is also found to be a risk factor, in addition to aggressive behavior. And then finally, favorable parental attitudes to alcohol and drug use is also a risk factor at this age. So in addition to friends, parents are still a great source of influence as well. And it's really important that parents model good behavior when it comes to drinking in front of their children. So if a parent is, for example, kind of always having a glass of wine or a beer at night, to wind down or de-stress, that behavior may be modeled in their children. So making sure that we're trying as best as possible to model effective coping strategies for children is really important as well. Finally, then we have some adolescent risk factors for alcohol and other drug use. So this includes perceived and actual level of community drug use. And the perceived part is really important here. So regardless of whether everyone around a young person is doing drugs or not, if they think they are, that's enough to have an influence on their own behavior as well. And this sort of element is something we will touch on again when we talk about effective prevention programs in the next part of the presentation. More practical risks include the actual availability of drugs themselves. We also have parental alcohol and other drug problems, poor family management, and school failure as well. And then, as we've sort of already touched on, there's deviant peer association. So if you're friends with someone who are drinking, you're more likely to match your drinking behavior to them, as well as delinquency and your own internalized favorable attitudes towards drug use during adolescence. So the good news here, though, is that many of these risk and protective factors are modifiable, they're actionable, and now we know what they are. They provide us with really important targets for prevention strategies that are aimed at reducing alcohol and other drug use and its negative outcomes. So protective and risk factors will serve as the basis for prevention programs. What I'm going to move into now is the final section of our session today. And what I wanted to do is discuss what makes a prevention program effective. So I'm going to touch on principles of good prevention practice, the settings and populations in which prevention can occur, as well as some of the do's and don'ts, or the goods and bads of prevention programs themselves. All things that can be really good to sort of bear in mind and know about when you're coming across various prevention programs or hearing about things and such. So good prevention will involve making sure the following 5 points are addressed thoroughly when you're sort of in the development stage. So the development and implementation of alcohol and other drug prevention programs will require a buy-in from a range of key stakeholders. So they will need to be involved in the buy-in stage and also in ongoing feedback and engagement throughout the project as well. And as Tara mentioned earlier, these stakeholders will differ depending on the community that we're looking at and also depending on what resources are available to you. But they may include health professionals, schools, community, and local drug action teams, as an example. The other thing to remember is that there's no one-size-fits-all approach when it comes to a prevention program, and there's no silver bullet or magical solution to this really complex problem. So instead, the prevention approach would be multi-strategic, multi-level, and well-integrated to include a wide range of strategies that will work together to achieve the desired outcome that we're looking for. Any alcohol and other drug prevention strategy needs to be culturally secure. And what we mean when we say culturally secure is that it's cognizant of cultural norms and processes. It's reflective of the rights and the values, as well as the expectations and beliefs of the community in which it is being run. So this is incredibly important, and that research and that understanding needs to be established prior to implementation. Prevention projects should also be guided and supported by a well-researched and evidence-based needs assessment and a strategic plan that has identified the priorities within a specific community. So there's no point coming in developing a prevention program for e-cigarettes if the community in which you're operating doesn't have a bad problem or high rates of e-cigarette use. And instead it would benefit a lot more from an alcohol specific program. So doing that needs assessment in a robust evidence-based way prior to any sort of development is really important as well. Finally, the prevention strategy should be reflective of the best available evidence of what works to prevent and reduce alcohol and other substance use related harms. And evidence-based is something that's really important, and we just wanted to spend a little bit of time expanding on that point again. So if we say something is evidence-based, it means it's been informed or supported by research. And when considering what research is supporting it, it's also important to consider the quality of that research. So for example, a published article would be a more reliable source of evidence or research than an opinion piece would be, for example. So keeping those considerations in mind as well. In the context of prevention programs, to say a program is evidence-based means that the effectiveness of the program has undergone really robust testing in a research study. And this will involve assessing the effectiveness of the program over time. So you really want your prevention program to not just, change people's minds in the moment, but you want to see long-term behavior change as a result of that program as well. For other prevention type resources that are available, this could be fact sheets, referral guides, or sort of more text-based resources that you come across. Saying that this is evidence-based would have involved conducting a review of published research studies about that specific topic to make sure what's being said in the fact sheet, for example, is backed and supported by the research, it's fact-based, and it's up to date as well. Evidence-based is something that at the Matilda Centre we do a lot of work on the various prevention programs that we're across. And given its importance, this is something that we are going to touch on again in the next session that we're holding that's focused on positive choices. So in the next session, there will be a bit more detail around what evidence-based means, what it might look like, and also in the context of the Positive Choices initiative at the Matilda Centre that both Tara and I work on as well. Next, I wanted to just outline some of the many and varied contexts within which effective prevention can take place. So the most obvious population, as Tara's already mentioned, given the importance of delaying age of onset, is children and young people under the age of 18 years. So that is the most frequent focus, I guess, but other contexts are as important and useful as well. So other contexts and populations might be Aboriginal and Torres Strait Islander communities, parents, families, so as we touched on in some of the risk and protective factors as well, people in rural and remote areas, people with co-occurring mental health and alcohol and other drug concerns, sporting clubs, local government councils and schools. And it might be worthwhile just taking a little moment to think about if there's any of these contexts or populations or others that we don't have listed here, within which you might operate within, or populations you might work with, where you might be able to have an impact when it comes to prevention of alcohol and other substance use. So just to sort of bear that in mind and think about where your influence might be. At the Matilda Centre, our expertise focuses, and the bulk of our research focus is on school-based prevention. So because of that, I just wanted to spend another little minute just discussing school-based prevention in a little bit more detail and explaining that. So research has shown that schools are an ideal context for drug education and prevention. And there's a couple of reasons for this. Schools provide us with an opportunity to have a really broad reach, and they also enable us to really easily tailor messages to various developmental levels. All the year 2 students are all together and all the 12-year-olds are all together, so it can be really easy to target developmental levels. Performance at school, school success, not dropping out of school is also, because there are risk and protective factors, this is also a context within which we can really actively target those risk and protective factors. And finally, youth spend 25% of their waking life in school. So this is a substantial amount of time. And this will allow us to implement ongoing and structured programs and sort of follow the children through the various years of schools. So in terms of prevention programs themselves, a number of research studies have identified key components of prevention programs that do contribute to their efficacy. And these can be really useful to be aware of and know about when coming across different programs. The first is that effective programs tend to use interactive methods. So this would involve getting program participants involved in the various activities, involved in sort of a hands-on way in the various learnings, and engaging with each other as well as with the program facilitator. Programs that are delivered by a trained facilitator are also more effective than those delivered by someone who's not been trained in the specific content or the specific implementation of a program. And as I mentioned when discussing the school context for prevention, programs that are delivered through a series of structured sessions, so over a period of time, are more effective than single sessions. Programs that dispel misconceptions about the prevalence of substance use have also been found to be effective. So an example of this is that it's a commonly held belief that most young people will have tried drinking or an illegal drug at some time, but this is actually not the case. So dispelling these misconceptions is really important because as we were mentioning earlier, if a young person believes their friends are doing something, they are more likely to adopt that behavior themselves. So dispelling misconceptions about substance use is really important and has been found to be effective. The program should also promote realistic and relevant perceptions of risk when it comes to substance use. So this will include both immediate consequences, importantly, as well as the more longer-term consequences. Drug and alcohol education is not enough for an effective prevention program. The opportunity for skills development in areas such as communication, help seeking, problem solving, and stress management is also really important, such that when an individual finds himself in the context where they might be exposed to a drug, not only do they know about the drug, but they know how to handle themselves and how they want to respond to that situation as well. Finally, prevention programs that are found to be effective often use the comprehensive social influence model. And I just want to quickly explain this in a little bit more detail. So this includes the provision of accurate and relevant information. So not about sort of instilling fear or sort of exaggerating anything. The facts about evidence and evidence base around drugs and the adverse effect that they can have. It also provides young people with the tools to make informed decisions, so resistance training, life skills. As we were saying, as I was saying just previously, this really equips young people with the skills to respond in various situations. And finally, again, it's important to challenge the view that everyone is doing it, driving home the message that most people do not take drugs and do not drink alcohol. So we can see that some of the components of the comprehensive social influence model do overlap with some of the characteristics that have been found to be effective in prevention programs, but this is sort of a whole model that will always use the three of them together. It's also important to be aware of research that's shown some characteristics to be ineffective when it comes to AOD prevention. Some of these are the opposite to those we've just spoken about, and some of them are unique as well. So we'll just go through those. So the first is a non-interactive or lecture style presentation that is given to young people. These tend to not work. There's also a strong body of evidence showing that scare tactics are ineffective when it comes to prevention. So scare tactics really became popular around the 1960s and can still be seen today. I think you might be most familiar with them from drink driving ads as a popular place for them to crop up. And also some of the very first COVID-19 vaccination campaigns that were run also had some elements of scare tactics within them. But essentially their overall aim is to instill fear in an individual around the use of alcohol and other drugs. And they tend to focus on and encourage almost exclusively on abstinence. And they have not been found to be hugely effective. Programs that focus only on self-esteem and emotional education is also not going to be effective. So it needs dynamic skills and education focus, which we've discussed previously as well. The program also needs to do more than focus exclusively on ethical and/or moral decision-making when it comes to substance use. Also, unstructured dialogue sessions have also been found to be ineffective. So we often see this in the form of former drug users' testimonials. These have not been found to be effective. Finally, police officers as facilitators delivering a prevention program are also haven't been found to be hugely effective at prevention either. So there's quite a good amount of research about, what does work and what does not work in the context of prevention. But these do tend to be based on studies with relatively short follow-up timeframes. And currently there is limited evidence available about the longer term benefits of prevention programs. So this is just something to be aware of. And I wanted to just give the context of what it is we do know, where we're at, what still needs to be figured out. So some international studies have shown that prevention programs delivered in secondary schools can reduce substance use up to 9.5 years after the program was initially delivered. So that's quite a substantial amount of time. In the context of Australia, the longer term benefits of school-based prevention programs into adulthood are currently under investigation. So we're doing the studies, need a bit more research to be done. But what we know so far is that there is evidence for their effectiveness and for their benefit in terms of reduced alcohol use and related negative outcomes has been found with both universal and selective programs, like Tara was talking about earlier, for at least 3 years following delivery. So these findings come from the climate schools and the prevention programs, both of which you're going to hear more about in the upcoming webinar sessions for this series. So I wanted to give sort of a quick wrap up. We've covered a lot today and a lot of content. We talked about what primary prevention is. We talked a little bit around harm reduction, supply and demand, alcohol and drug use statistics in Australia, as well as the importance of prevention and that age of onset mark as being a really important time, as well as what makes a prevention program effective. So we will be moving into a Q&A and discussion section now, but I just wanted to say as well that most of the content that we have covered today does come from a 3-part fact sheet that's available on the Positive Choices website. So the program that both Tara and I are working on. So the first is why is drug and alcohol prevention important? The second is school-based drug and alcohol prevention, what works? And the third is school-based prevention, choosing resources. So kind of a lot of the information can also be found there should you want to refer back to it at any point. But I think now we will open up into the Q&A section of today. So thanks very much, everyone.
Thank you so much, Emma and Tara. And we have got some questions that are coming through on the chat. So that's really encouraging as well. Please do use the chat bar. Are they able to unmute themselves to ask questions, or are we only going through the chat box?
I think if people use the raise hand feature, I may be able to unmute them, but otherwise, yeah, feel free to put questions and comments as we're talking in the chat as well.
Okay, so we do have one in there from Miriam. Do we know why the age of drinking is increasing in adolescence? Is the change due to increased knowledge of the adverse effect of alcohol on the brain, or is it because of the availability of other substance like cannabis?
I can take this one, Emma, if you want. When I saw this question come through, I was so glad someone asked it, because this is the big question, really. And there are many researchers at Matilda Centre and just in the alcohol and other drug space that are looking into this. And unfortunately, there's not a clear answer. So there's been sort of many theories proposed, some of them mentioned there. So is it a better understanding of the risks to do with alcohol use? Is it to do with the availability of other substances? Is it to do with social media? We know social media has been a big rise in the past sort of 10 to 15 years. Is it to do with changes to how we socialize now? Is it to do with other parenting factors of parents sort of getting better at modeling and monitoring alcohol use? Unfortunately, we cannot say it's clearly any of those things. It's sort of a frustrating answer, I know. But sort of, it doesn't look like it is social media. And because there hasn't been an increase, I know I didn't have it on the slides, there hasn't actually been much of an increase in cannabis use across from 2001 to 2019 with the drug strategy survey. There has been some fluctuation, but not, you know, an increase in age of alcohol use and then an increase in cannabis use. So there's not that clear relationship there. But I guess it's hard because once we know what is helping delay that alcohol usage, we could harness that, but we don't know, unfortunately. So I'm sorry that we can't give a clear answer.
Definitive one, and I think that that's an area that does shapeshift quite often, so it's paying attention and keeping an eye out on what's emerging and what some trends are in that space. A comment that was made as well is it's interesting, and this was with Tanya Tuckerman, it's interesting that there is no mention of situational distress and risks and responses to grief, especially losing someone to suicide. Is there any research that you've done around situational distress and the uptake of use of alcohol and drugs?
I could take this one, Emma, or did you?
Sorry, I was just answering some of the questions coming through on the admin side in the chat. Are you happy to go for that, Tara?
Sure. So definitely we know that there is very strong links between trauma and situational experiences and alcohol and other drug use. I guess it's harder, that slide that Emma focused on when we sort of talked about some of those risk factors was mainly amongst youth. So it's hard then when we're looking at the research side to get a population of people who have experienced these situational experiences of suicide to then, you know, understand though their alcohol and other drug use. So I can't say definitely, but we know that there is strong links between trauma and alcohol and other drug use, definitely.
And I think this next one that Tanya also posed may have been addressed by you, Emma, as something that's not considered. But the question was, have you considered delivering programs with people who have a lived experience? People with a lived experience of substance use can be invaluable in sharing their experiences.
Yeah, no, lived experiences definitely has a place in prevention and an important place as well, as long as it is sort of built into some of the do's, I think is what I call them, of prevention. So not just a one-off session, some sort of, you know, interactive element would be important there as well.
Yes,
so thank you for that. Jenny, just wondering, we're hoping that you have found on the Positive Choices website where the printouts are found, but if not, we'll make sure that we share some links also when we share the recordings. A question from Paula. Hello, Paula. I'm familiar with Paula. What are you noticing about the effects of COVID on university students' AOD use?
I don't know so much about university age. I know if we're looking at sort of broader population, there hasn't actually been as high increase in alcohol and other drug use as expected. So there is some data saying that amongst youth, not necessarily university, so say 16 to 25, that there has been a decrease. Well, I don't want to say a strong decrease, but, we're not seeing huge spikes as we may have proposed. And this could be, maybe people aren't drinking or using alcohol and other drugs in the settings that they were previously, can't go out to nightclubs, that sort of thing. But there's definitely been within specific populations some higher spikes. So I think we can't say definitively that there is a, I think everyone was proposing when COVID broke out, suddenly we were going to see this spike in alcohol and other drug use. Definitely seeing it, some reports, but some are saying no. So I think a bit of a watch this space, and just seems like everyone's collecting data on this. So we just got to wait for it to come out.
It is, it's an interesting situation that we find ourselves in. The life that we knew as being normal keeps shape-shifting every day. So it is interesting to watch what we're actually collecting in data and how that's actually impacting on people's well-being as well. Emma, I do see that you've actually addressed this one. Yes, the recordings and the presentations will be shared with everybody that has registered with us. So we will be in contact with everyone to ensure that you've got links that go through. We have a question here from Kyle Single. Any predictions around the legalisation of cannabis across the state? Interesting question.
I can say my bit if you want to say something as
Yeah,
well,
you
Emma.
can go first and I can give my thoughts then.
My prediction is, I don't know what the prediction is going to be. I know it's been a topical conversation, especially since the US a few years ago has legalised it. And sort of in that National Drug Strategy Survey, they actually have a question about, I can't remember the specific wording, but it's sort of like, do you approve of the legalisation of cannabis or other drugs or that sort of thing, or the decriminalisation? And definitely at a population level, people are more agreeing with that question. So they're more for the legalisation and decriminalisation. Whether if the population's opinion is actually going to influence policy, that's another question.
Yeah, I think it's definitely going to be a really interesting space to keep an eye on over the next couple of years, and how those sort of outcomes are measured and what they look like. It will be interesting as well because there are, in terms of perceptions and stigma and things, there's quite a lot of difference between alcohol, which is considered a legal drug, versus illegal ones. So it will be interesting to see if that shifts the perception around cannabis as well, and what those consequences might be.
You moved straight into the second part of his question there. So well done, Emma. Thank you. Another one from Paula. I don't know if you saw that, whether it was good luck or good management. Another one from Paula. Out of those available, if you were to recommend one guide or a how-to on developing or / planning drug and alcohol interventions, what would you suggest?
I can't say there's a one guide. That there's sort of the summary in that 3-part on positive choices. Some of that is a bit more tailored towards schools, but I think could almost just pull out the key things across those 3. And if it wasn't in a school setting, sort of disregard anything like that. That helps.
No, yeah. I know with Paula's situation, it's definitely university students that they focus on and target. It's and like you say, I don't think that there's any one size fits all approach. There's a myriad of practices and programs out there that we can explore and reach into and see what works best, I think, for the people that you're working with as well. There's lots of thank yous, and yes, thank you. We're glad, Jenny, that you found it. Ben from Parramatta has stated here, he's been talking with some high schools in his CDAT area who have said that vaping is a growing thing amongst students. Would your research consider vaping or smoking cigarettes?
So we definitely, at the moment, research is counting them as 2 things. So if they're asking about cigarettes, they're talking about traditional cigarettes, and then they would also be asking questions about the e-cigarettes as well. So definitely wouldn't say they're both the same, especially because we know that a lot of young people who are using e-cigarettes have actually never tried a traditional cigarette first. So that's sort of a growing concern as well, where people, it's different, maybe someone was using a traditional cigarette and now they're using e-cigarettes, but I guess the concern are those that were never using traditional cigarettes and are now trying e-cigarettes. So yeah, we'd call it still smoking, but yeah, definitely like to distinguish between the traditional, that's sort of what wording we use, and then the e-cigarette.
A really sort of hot topic for research at the minute is sort of figuring out that relationship a little bit more. You know, does e-cigarette lead to smoking? Are there shared risk factors? And that's another space we're keeping a little bit of an eye on. But yeah, as it becomes more sort of known and more distinct, as Tara said, the language is changing to distinguish between those two.
It's certainly a hot topic question that's coming up amongst our CDATs this year, and it's something that we've had to explore as to how can we support CDATs in that space. So we're definitely interested in learning more of what's actually going on in the communities and collecting some of that data. So the connection that we have with the Matilda Centre, I'm hopeful that we'll be able to segue some of that information in quite nicely, and we'll learn a little bit more about that. So Ben, watch that space, but keep us in the loop of those conversations as well, which is really great. So Roderick Smith, I don't think it's necessarily a question, but more of a statement of he's known at least 5 people over 30 who have ended up in hospital overdosing on e-vapes. Have you got any information around what it might be with regards to how that may have happened? Is it a contribution of a number of things?
One of the things when it comes to e-cigarettes is that dosing is quite a bit trickier. You know, if you're smoking a cigarette, it's a cigarette. Whereas if you're using an e-cigarette, you can sort of keep puffing away for quite an extended period of time. Given the sort of legalities around it in Australia in particular as well, they're not coming from regulated suppliers. So we don't necessarily know what was in the vaping product that was supplied to someone, which might also be contributing to the really serious adverse health effects that was what Roderick was mentioning there.
It's certainly.
I was just going to say, I think that unregulated nature of e-cigarettes as well. We know a lot of people, they're purchasing them online or at corner stores where, you know, they're illegally selling them. So I think it's one thing to be able to, measure and control of something like cigarettes, which are just sold over the counter, versus e-cigarettes, which, it's such an unregulated space at the moment.
It definitely is. I know from our perspective of talking with the ministry that they're very keen to hear what it is that we gather in the data from the ground of what's actually happening in communities and how it is, like I say, that we can segue that into the research that's being undertaken to provide some more evidence-based knowledge in and around that. Next question, and please forgive me if I pronounce your name incorrectly. Tapu, I believe. What is the uptake of Aboriginal populations towards prevention, harm reduction programs delivered in their CDAT areas? It's probably a question for us, actually, in that sense. I'm not sure that you girls can answer that. What we are actually seeing there is we're working to collect more of that data, and I'm really interested over the duration of our work with the CDATs across the state to actually collect more of that information as well. The program that was referenced earlier by Emma and Tara is a great opportunity to engage with Aboriginal populations in and around prevention and harm. So we can certainly provide you with direct links into that, and then let's gather more data. We know that anything that does work towards prevention and harm reduction, when it comes from a community perspective and people working towards it, that we always see some sort of change. So we'd certainly like to learn more about that and give you more concise and precise data around that. Eva has just made a comment, there is definitely a big issue with kids in primary school at buses vaping. Yeah, we are seeing a huge uptake there in and around those spaces, and it is quite alarming that they are so young that are taking that up. And as we've said in some of the learnings that we've undertaken as staff, and the people that we're taking our learnings from, is that the harms around it's great to see that there's a reduction in tobacco uptake, but because we're so uncertain as to the harms of vaping, that's another really large concern that is out there in the community. Emma, you've responded to Paula, so that's really fantastic. Katerina, do you see the use of role models, sports actors, etc., useful in campaigns?
Interesting question. And from the research, I know there's no, it's sort of hard because there's definitely been campaigns where they have used those sort of people, but it's then that evaluation side. So these campaigns are often run, but then there is an evaluation of how effective they have truly been. So there's definitely no research in that space where they've evaluated the long-term effects of a campaign that uses, role models, sports people, or actors. I don't know.
Yeah, it would be an interesting one to have a look at for sure. My gut is sort of saying that yes, just based on sort of the talk around influencers, sort of at the minute online on social media and things and the influence they can have. But yeah, as Tara said, there's not an evidence base to back it up, so we'd have to figure it out.
Definitely.
I think it can be a very fine line as well. Sorry, girls, a very fine line as to, we know that sport has a huge protective factor in a number of particularly remote and rural communities. We see a lot of real connection in those communities around sport. It's a big factor. It can be, it's that weighing up of the scales, really. It can be a really good thing, but then we also see that as some of the role models grow and perhaps some of their choices aren't as positive, that can also impact on communities. So it is a fine line in and around those space. Okay, so
we've just got a few in the Q&A box.
Do you have an example of a successful and effective prevention program that has helped with long-term change within the community or target group?
Absolutely. So the third and fourth webinars of this series are going to go in depth into 5 different programs. So the biggest one is Climate Schools. So that is an alcohol and other drug prevention program that's been trialled for past 8 to 10 years across 14,000 students all across Australia. And there's a really strong evidence base for that program in reducing alcohol and other drug use, increasing knowledge of alcohol and other drug related harms, reducing anxiety and related symptoms. So Climate Schools definitely the top one there. And in our third webinar that we'll be going much more in depth into that program.
Yeah, we're certainly looking forward to diving into those ones and learning a bit more about how they actually work within communities. Another question that we have from Beth Bolt of, have personalised use of apps, e.g. Leaf, for prevention had a positive effect?
I'm not familiar with Leaf. Are you, Tara?
No, I'm not. And I'm not sure. Maybe Beth can say if Leaf is targeted more at youth, or is it for people who are already using alcohol or other drugs? Leaf makes me think it's related to cannabis, or maybe marketing isn't that great. I don't know.
Or our heads are in a different space.
Yeah, but I guess maybe I'm just assuming, is it maybe sort of a tracking type app where people are tracking those who use alcohol of any age? Haven't heard much about this app, but now that it's on our radar, we can definitely look into it as well, because on Positive Choices, we actually have like a list of recommended apps and that sort of thing. So has it come onto our radar yet?
And within the chat box, Mandy, thank you for doing this as well, you'll see that Mandy's actually populating quite a number of links. So there's links in there for Climate Schools. There's an awesome vaping webinar that the Matilda Centre have put on as well. So there's a link in for that particular webinar. But yep, you've put it in there twice for teachers. So there are a lot of opportunities for those that are online with us to really dive into the Matilda Centre. I know that we've done it in the conversations that we've had in working with both Emma and Tara in developing the series for the CDATs. There's a lot of information that is out there. Perhaps a question that I have, and one that we would get a lot of for the CDATs, is when we often dive into finding programs and resources, how is it that we can stop ourselves from going down rabbit holes and then finding a million different programs? How can we assist in verifying, or at least providing more confidence to CDATs that the programs that they're tapping into are reputable? What are the sort of things that they should look for when looking for a program that helps them around primary prevention?
Maybe I can start, Emma. Yeah. I was going to say, we'll go into this in a bit more depth in our second one when we're talking about evidence. We talk into, research studies. It's always, I think evidence is kind of thrown around a lot, that word. It's hard to sort of conceptualize what does evidence truly mean. So I guess from our perspective, and as researchers, we're really looking at things such as clinical trials and research papers. So this is a published study where they've taken the program, they've had maybe one group who gets the program, one group who doesn't, so a control group. They carry out the program, and then afterwards they evaluate or survey the people who did the program and didn't. So then it's comparing for that group who did receive the program, what were the benefits that were seen, or maybe there weren't any benefits. I think that's okay to remember as well. When you're looking for evidence, there may be a research paper about a specific program. Just because there's the paper doesn't mean it's necessarily effective. It's about trying to read the paper and just seeing what were their conclusions. So was there any positive effects? Was there no effect, or was there a negative effect? Probably not going to see a negative effect, but yeah, is there any positive benefits to the delivery? So Google Scholar, that's a really great place to start. And yeah, maybe Emma, if you want to add some things.
Yeah, I was going to say as well, having a look at how it's implemented and whether that is feasible in your context is also really important. So some of them can be really heavily involved. And even if it's effective, it's not going to be effective if you can't implement it to that level as well. So sort of bearing implementation in mind, I think is really important as well, just to add to Tara. We, on the positive choices as well, we do have a repository of programs that we have reviewed for their evidence base as well. That can be sort of if you're in a hurry, you can pop there and sort of maybe not have to do too much of your own figuring out, but we do. Anything that's posted or available via the Positive Choices website has undergone quite an extensive evaluation process by us and our team as well. So there's a bit of added confidence there.
And I think as well, it's tricky. There's definitely a lot of programs out there that aren't listed on Positive Choices, but evaluating programs can actually be quite expensive. I think that's even, working in a university space, it takes time and grant money to be able to implement these programs and then let the program run its course and then evaluate them. So there's definitely a lot of programs out there, and the gold standard, as we say, is sort of that research publication, which will say if a program's effective. But if that sort of information isn't available, it's not to say the program isn't great. It's then sort of looking into what underpins that program. So they might not have done that formal evaluation, but sort of what research did they use to come up with that program? I guess that's another thing to consider as well.
Sorry.
Given that we are asking the CDATs to provide us with evidence of programs or activities that they are undertaking, we often get the question back of what is it that we need to actually look for. Have you got perhaps a couple of points? Like, I know that you've just shared some information there around evidence base and where to find it and reputable, but would there be key things that you would look to include perhaps at the beginning to consider as a point of evaluation throughout the activity and program?
I think sort of something that's really important in evaluating and sort of ensuring your program's going to be effective in your population is also having a think about the needs of that population before you implement anything, and making sure that what you are creating or implementing or developing is catering those needs. Otherwise, you're not going to see evidence. I guess as a really take a couple of step backs sort of starting point to answer that question, Gail. I know it's not quite directly an answer, but an important starting point that will lead to subsequent evidence, I think.
And I guess as well, it's sort of what is the program or what you're trying to deliver? What do you want the outcome to be? So is the outcome just increasing knowledge of the harms of alcohol? So in that case, you would want to survey people at the start, their alcohol-related knowledge, and then afterwards, survey their alcohol-related knowledge again. If it's something more related to actually preventing the use of alcohol or other drugs, you'd want to be surveying, you to have that initial baseline. What is the alcohol and other drug use in that population group? And then after delivery, what is the alcohol and other drug use after delivery? So I guess, working out what is the program actually trying to achieve here? Yeah, I guess at the end of the day, what do you want to get out of this? What are you trying to help here?
Yeah, and figuring out a way to measure that.
Yeah.
And we can definitely point, like maybe this is something we can include in our next one, is some common, the sort of standardized scales for, measuring alcohol and other drug use. So for alcohol, there's the audit, so the alcohol use disorder identification test. So that's a 10-item scale that's really about, it's not just how many drinks you're having, the sort of 10 questions talking about how often you're drinking and which situations you're drinking in. So things like that are a good thing if you can incorporate them.
I know that from talking about the makeup of CDATs, people contribute their time on a voluntary basis. So there's a lot of people, and it's quite a mixture of people as well. So we've got people that are working in the industry on the allied health side of it, the peripheral edges of it, that perhaps aren't directly dealing with alcohol and drug, but are affected. They see people that are affected by it. In finding questions, and we often get this question as well, what are the right questions to ask? And you have given a demonstration there. Is there any cheat sheets or easy sort of reference guides that the Matilda Centre might have that we can guide CDATs to lean into to help them?
At the Matilda Centre, we probably have about 30 different questionnaires that we use. So we definitely don't have a nice simple cheat sheet, but we can, in our next presentation, look at thinking of some of the key ones that might be definitely good to include. Researchers don't make things easy for ourselves or for anyone, really. Yes, if you're asking about alcohol and other drugs, there's many choices and questionnaires that we could include, but you can definitely think of some of the key ones to include.
We've got Mandy working rapidly behind the scenes here. Mandy's just populated into the chat box as well. Again, Matilda Centre recommended and evaluated programs as mentioned. Also know of another resource with NADA around evaluation and takes it through the steps of it as well. Kyle Single has said in here, assist is great too. So assist, please clarify, thank you. And another question is, has assist tools been found to be reliable and valid for adolescents? I believe that thank you, Tanya, you've actually answered that there. Assist is applied suicide intervention skills training. It's fantastic. So Tanya, if there's a link, please, I encourage you to populate that in there. Emma or Tara, do either of you have any experience or knowledge around that particular tool?
I think I might be referring to assist for smoking prevention. So I know of an assist, or actually I'm getting myself confused now, that's Aspire.
There is an assist screening tool. We've just recently learned about that. Paula, and thank you. I'm loving that we've got actual knowledge coming from within our participants today. Thank you, Paula. Assist is a lifeline program, so it's an applied suicide prevention. And there's links going left, right, and centre. So that is fantastic. There you go. Thank you, Paula. She's popped that in there as well. So there is, as we can see, not just, oh, there we are. Look at you girls going there.
Yeah, but I was like, still screen share. Chaos.
This is the beauty of online and instantaneous. So obviously there are some of our attendees here today who have got some experience and knowledge and have been a part of that training, because we're getting a lot of really positive comments coming in there. Yeah, fantastic. All right. Yeah, there is an assist assessment and screening tool. Thank you, Michelle. Annie Bleeker, who is another facilitator that we're working with as well, that's watched that space, because there's more learning opportunities after we've completed this series, and Annie will actually be taking us through some of those as well, so keep your eye out for those. Thank you to everybody. We've still got a little bit of time up our sleeves. I encourage you that if there's any burning questions that you've got, please pop them into the chat or the Q&A. Raise your hand. Let's see if we can engage with you in that space. But perhaps in just waiting for some more questions to come through, I'd really like to thank Emma and Tara for working with us and coming on board. It has been an absolute pleasure to get to know the Matilda Centre more thoroughly, to really solidify our connections and our collaborations with them. And it is an opportunity for us to be able to provide first-hand, direct source knowledge to our CDATs as well. So we're extremely grateful for being so willing and engaging and behind the scenes watching us with our excitements as we actually work through developing this series as well. We've heard from our CDATs, as we said to you in our first initial conversations, that primary prevention and harm minimisation is the focus of the Community Drug Action Team program. So being able to provide the support to CDATs is really, really important, and we're super excited that you girls were the ones that got to kick off our first series of learnings. To everybody online, we have been saying this through the chats, is all of the sessions will be recorded. So if you need to jump in and out, we appreciate that time is very limited, even though it is online. It's still, you have busy days. So we will be providing the recordings. Again, we're going to lean into the experience of Tara and Emma, and they're going to help us to create, I'm going to put myself out there with this one, so I have to do it, a YouTube channel that you'll be able to have, like, go back and also listen to the recordings, but we will supply you with a direct link, and hopefully we'll be able to gather as much of the transcript as possible and just pull out of there some of the other things and lead you into some of those other publications as well. One question that's come up. Okay, Roanna, I'm not sure if Emma or Tara would be able to answer this question, but what we will do is take a note of it and perhaps ask Annie Bleeker. The question is, do you know whether the ASSIST, which is alcohol, smoking and substance involvement screening test, has been validated for use with youth? Is that something, I think if we've just thrown that at you, are you familiar with that?
I don't know it for use amongst youth and if it's been validated, but it would be I'm sure we can do a quick literature check and see if it has been used. I know I can say that we don't use it for any of the Matilda Centre projects. We've got a few other screening tools that are usually used for the school or youth populations. So ASSIST isn't what we usually use, but that's not to say it's not been validated, but yeah, we can definitely check that.
Like I say, I believe, because this is a conversation that I have had with Annie Bleeker, a TODA might actually be able to provide us with a little bit more information of whether or not it's been validated with youth. But we'll definitely follow that one up. So to my lovely girls behind the scenes, Abby and Mandy, if one of you could capture that, that would be fantastic. Thank you for those lovely words, Paula. This is about you guys. It's about the CDATs and the participants and the volunteers, all the people that contribute their time. We want to be able to support you to know where it is that you can get information from, how it is that you can implement a program, and know that it may have some impact within your community to, you know, shift the mindsets of people of how they actually see drug and alcohol, to help with those that perhaps have a particular lens, to maybe give it a different shade, to see something different. And then, you know, we'll be able to support you as we move along. We're getting a lot of thank yous, and we are extremely grateful for everybody attending and joining us. Something I'm extremely, and the girls, all of the girls behind the scenes, Emma and Tara included, have felt my excitement as every day we have more and more registrations. So we're really proud to acknowledge that we've had 120 registrations for our series that's coming across. I do apologise that there has been some confusion. So for those of you that went, oh my gosh, I thought it started at 2:30, it is actually 2 o'clock. We've made sure that all of those things are very well aligned. If you have any questions or queries, please don't let this be your last opportunity. We will be running the second session. Thank you. A lovely segue there. That wasn't even practice. Well done. Thank you. So our next session, as you can see, is Wednesday, the 13th of October, 2 p.m. You will receive your reminders via Zoom link, so they will still be coming out to you. You don't need to re-register. Everybody that's online with us today and everybody that's registered has registered for all of the 4 within our series. As you can see, we will be taking a bit of a dive into positive choices. So I'm really excited to see. I've had a bit of a surf around. I've worked well with positive choices over the duration of my experience with the Community Drug Action Team program as well. I've handed out a number of post-it notes across the state in the previous portfolio that I carried. Thank you again, Emma and Tara. You've certainly given me other layers of primary prevention that I didn't know about, and I'm going to explore those a little bit more. I'd like to just again thank everybody for joining us. You've got 5 minutes up 5 to 7 minutes up your sleeves with no more questions coming through, and we'll see you in 2 weeks. Thanks so much, ladies.
Yes. Big thank you,
Gail. Thanks everyone.
Mandy and Abby, and for everyone for coming. And feel free to email us at those email addresses if you need or have any questions as well.
Yes, just everyone will get the links to the recording and the slide handouts as well. So Zoom will automatically send that to you as a participant and anyone else who registered as well. So they won't come straight away, but they will definitely come within the next 5 to 7 days. So no need to worry.
Yeah, there'll be a couple of touch points, so they'll get them directly. We'll create the YouTube channel, and this is something that a lot of our attendees wouldn't know at the moment, but we'll also be placing that on the recently launched CDAT website as well. So there will be a few different places that people will be able to access the recordings. Thanks again, ladies, and we'll see everybody in a couple of weeks. Take care. Travel safe.
Bye.
Bye for now.